and get started. So Intensive Pediatric Physical Therapy 101. There we go. All right, so our goals for today, for this webinar, is to discuss the population of population of patients who could benefit, to define what intensive physical therapy is, to talk about the treatment approach, and also review the specialized equipment that is used for intensive therapy. We'll touch on some of the research findings, talk about maximizing and maintaining the quality of care, how follow-through at home is important, and the home exercise programs that are created. And then, again, as Dawn mentioned, we'll have time for questions at the end. So, diving right in, what populations benefit? Intensive therapy really is helpful for children with neuromuscular disorders. So the most common diagnosis we see is cerebral palsy, but we do see a lot of different diagnoses. Some kids maybe don't have a specific diagnosis and it's developmental delay at this point. Others may have spina bifida, traumatic brain injury, different metabolic disorders, and then there's lots of different genetic syndromes that we work with. So some common Down syndrome, Rett syndrome, Angelman, but as a lot of you probably know, there's many rare genetic conditions, and we have been lucky enough to work with some of those kiddos as well. I think the most important thing is whether or not the neuromuscular disorder is progressive in nature. If it is progressive, like some of the muscular dystrophies, we need to really get a handle on what the diagnosis is and how intensive therapy would affect them. So with some disorders, intensive therapy might be a little bit too much for them, but we might still be able to see a child. It would just be for a less a smaller duration of time. So we do look individually into each child and what their diagnosis is. I do want to touch on the prevalence of cerebral palsy in comparison to some other pediatric disorders we hear a lot about. We hear about leukemia, muscular dystrophy, juvenile diabetes, of course autism, but if you look at these statistics, 1 in every 278 8-year-olds has CP. So in comparison to some of these other disorders, it's pretty prevalent. And you know, we just had World CP Day last week, and just continuing to create awareness so that we can continue to raise money for research to treat cerebral palsy and also in the future to prevent it. So I think it's important to know these statistics and help create awareness so that others realize that CP is something we should be, you know, researching and trying to help those that have it. So this slide here talks about some discoveries made in the last couple of years, which are very promising for kids with neuromuscular conditions. So it used to be thought that when preterm babies had low blood or oxygen flow to the brain, that it would cause an irreversible loss of brain cells. But the great news is that it does not kill those brain cells. It actually disrupts the cell's ability to fully mature. So if you look at the picture, the cell on the left is a normal cell, and it's got lots of branches you see. And then on the right is a cell that was had some lack of oxygen. And you'll see that the branches aren't quite as long, there aren't as many of them. And what that truly shows is that that cell is not fully mature. So what research has found is that therapies, you know, the earlier the better, therapies are able to help promote regeneration and repair of the premature brain and those brain cells. So it's just awesome to you know, have this research and to know that there's so much hope for these kids. So I want to talk about the different physical therapy models. Many of you, I'm sure, are aware of the first two. So the first is the educational model. It's delivered in the school system, and the goals must be focused on the school setting and that child being able to learn in the school setting. So it is limited to that school setting and their education. It's typically 20 to 30 minutes a week, and again, everything's focused on, the child's access to education. So it might be their sitting posture. It might be how can they efficiently get from one class to another class if they're, in junior high or high school. But the therapists are limited to working on some of the other functional skills that the child could be working on, just because it may not impact their education. The second is the traditional outpatient model, and that's 1 to 2 hours a week. Quite often it's once a week and ongoing for quite some time. And their goals are to maintain and improve functional skills. So now we have this third model, intensive physical therapy, and that's anywhere from 6 to 20 hours a week. And the goal is new functional skills through repetition and strengthening. So the definition of intensive PT is therapy up to 5 times a week, up to 4 hours per day, which equates to 20 hours per week over a 2 to 4 week period. And really what it is it's cycles of this intensive therapy followed by rest periods or traditional therapies. So it's not like a child would just do intensive therapy from here on out. We've got lots of kiddos that will come to us for maybe a 2 or 3 week session, and then they'll do some hippotherapy or aquatic therapy. Maybe they see their traditional outpatient therapist in between. It really does fluctuate, and it depends on what's needed for each child. Intensive PT allows enough time. I mean, time is really the key factor here. Enough time to use specialized therapy tools, and really the treatment plan is much broader because we do have this increased time. The time also allows the repetition that's needed to create new motor skills. So I'm going to go over some definitions with you. So the definition of learning is the formation of new synaptic connections in the brain. And we learn through practice. And practice equates to motor learning. So motor learning is kind of tricky, but the definition is that motor learning is a set of internal processes associated with practice or experience, leading to relatively permanent changes in the capability for responding. So basically it's those movements that become automatic because you've practiced them so much. So basically the more we practice, the more we learn. And this is documented in research, of course. So I quoted a statement from an article by Shumway, Cook, and Woolacott that states that in any given therapy session, the number of practice attempts should be optimized. So again, with just more practice is what's needed. When we learned to stand up as babies, we stood up and we fell over. We stood up and we fell over and over again until we mastered that skill. So with these children that are affected, their practice attempts need to be more frequent in order for them to grasp that new skill. So, the more practice we can get in, the better and more functional they'll become. So I wanted to just put this statement out there. We're going to talk a little bit about research in a little bit, and I just wanted to suggest that 10 sessions of intensive PT over 2 weeks may be as effective as 30 sessions over 6 months of a less intense therapy program. So we'll talk about that in just a little bit. So on to the treatment approach. Therapy begins with an initial evaluation. So a physical therapist is with the child, and usually the parents are also in on the evaluation. So the physical therapist, of course, assesses the physical condition of the child or young adult. They're checking their range of motion, their muscle strength, their function. Are they able to sit up by themselves? How is their balance, their coordination? Are they able to transfer on their own? Can they crawl? Can they walk? Do they need assistive devices? So all of these things are assessed. And then there's also, communication that's happening. We reach out to the parents and ask, what concerns do you have? What would you like your child to be able to do better? And if the child or young adult can speak for themselves, we certainly want to know what their goals are and, you know, what would they like to get better at. So once that initial evaluation is completed, a treatment plan is established and goals are set. It's usually 5 to 6 goals. And then that's really what we're focused on during that session. When therapy begins, it typically starts with an individualized preparation period. And what that means is that we use a combination of different modalities depending on what the child needs. So it may include some hot packs, some massage, some manual therapy techniques. We might use electrical stimulation. We might do some sensory integration techniques. We're certainly going to do range of motion and stretching if there's any tight musculature. And we're also going to do strengthening as well. So just to talk briefly about stretching, muscle length is necessary for function. If we have shortened muscles and we can't move our arms and legs as much as we should be able to, it's going to affect our ability to carry out functional skills. So there's lots of ways to do stretching. You can do them actively, meaning you're participating or the child's participating, passively, which means the therapist is doing the work, or maybe the parent or a caregiver, and prolonged stretching. So an example of prolonged stretching might be a child's having a snack in the middle of their 4-hour session, and we will actually, to stretch their hamstrings, we may put them in a seated position with their legs spread with some sandbags on them, and that's actually stretching those hamstrings while they have that snack. Research has shown that stretching increases range of motion and creates lasting results. So if there's tight musculature, we are going to address it and we're going to do some stretching. Strengthening is also a really key component of an intensive program as well. It used to be thought that strengthening may cause an increase in spasticity for those who already had spasticity. But luckily, there's been more research that has shown that that's not the case at all, and that, quoting Morton, that they found no adverse effects accompanying the positive outcomes from strength and function. So it is really important for all children to do strengthening. Even those children that have increased spasticity and appear to be really strong, and it looks like they have really buff, strong muscles, there's usually underlying weakness. So that's definitely something we want to address. As far as the preparation period being individualized, I just mentioned spasticity, and that's one example. So for a child with high tone, their muscles are always going to appear to be turned on, and it creates muscle imbalances because those muscles are always turned on, and it creates at times contractures. So what we do with a child that has high tone or spasticity, hypertonicity, you may have heard, is more relaxation activities. So a lot of times we do use hot packs, we'll do massage, we do different manual therapy techniques to get those muscles to relax, and we're also going to do the stretching that I had mentioned before and strengthening as well. Now, for a child with low tone, and a lot of times some of the children with genetic syndromes have more low tone. Low tone is the opposite of high tone. So the child's going to appear more floppy, more relaxed. They have joint laxity, decreased body awareness, and lots of muscle weakness. So we're certainly not going to be putting hot packs and stretching their body. Instead, we're going to do more stimulatory activities, trying to kind of wake their body up. So some sensory techniques, and also lots of strengthening, like I mentioned. Many children have a combination of both high and low tone, which is called mixed tone. So that's the most common presentation of CP is mixed tone. A lot of times children will have higher tone in their extremities and then lower tone in their trunk. And again, it just really stresses the importance of an individualized plan so that we can address what each child has going on. So after this preparation period and strengthening, we move into more therapeutic activities. So that can be balance and coordination training, functional activities. So, you know, maybe transferring from crawling into a seated position. That takes practice in order to figure that out. Sometimes kids get stuck in a position because they're not quite sure how to safely transfer. It might be a child transferring in and out of their wheelchair. Maybe it's bed mobility, being able to roll over and sit up at the edge of the bed. So lots of different functional things that many of us take for granted and that we'll practice working on. Also gait training. So for children who are learning to walk, or maybe they walk with a walker, and we're going to introduce forearm crutches, or maybe even independent steps. So lots of different therapeutic activities that are done. We do use a lot of different methods and techniques as well. I know some therapists practice strictly NDT, which is a common pediatric approach, but we use a combination of lots of different treatment methods and techniques. So NDT is one of them. I had mentioned sensory integration before. We also do partial weight-bearing treadmill training, in which the children will you know, practice their gait pattern on a treadmill, and we use a device with a harness that lifts some of their weight off so they can focus on the pattern, and then we will slowly lower them down to carry more of their weight to make it more challenging for them. We also use PNF techniques. We do joint compressions, electrical stimulation, therapeutic taping, just some examples. And again, not every child would get all of these. You know, it's really what we think is best for each kiddo. So the primary treatment outcomes we're looking for is an increase in range of motion, improving their strength, their coordination, and their balance, creating new functional skills, and increasing mobility overall. Some secondary treatment outcomes that we quite often see that I think when you think about physical therapy you might not necessarily think of is increased confidence, security, and self-esteem. So when these kids become more mobile, their confidence increases. As they practice and they get more comfortable with certain skills, they feel more secure, and they're more willing to try to be more mobile out in public, for example, or at school. And their self-esteem is improved. So we're going to talk about the cage in just a little bit, but you see this little kiddo on the far left picture. A lot of times when kids stand in the universal exercise unit, that's often the first time they've ever stood without somebody holding them up. So just, you know, a lot of confidence. They're really proud of themselves when they're able to do that. There has been research on the benefits of activity in general, and I just wanted to go over those with you because it really ties into this whole, you know, improved self-esteem and confidence. So benefits of activity, according to Damiano, reduces depression, enhances learning and memory, reinforces neural pathways, and basically the overall idea is that neuroplasticity is positively reported in pediatric patients, and that is the capability to reorganize and recover, and they have found that it is best in early intervention. So activity harnesses plasticity of the brain and produces functional performance, likely through prolonged and intense activity that can be accomplished by focused therapy programs and by promoting a more active lifestyle. So again, you know, physical therapy, we want to increase the function of these kiddos, but activity in general is really helpful, and it impacts so much more than just movement. It really does affect the child's entire quality of life. All right, so now we're going to talk about the specialized equipment. There is a therapy suit, Euro-Peds has patented, and then we also have the universal exercise unit. So the universal exercise unit, which we often, the therapists, call the cage because it does look like a cage. For those of you who have never seen it, the front is completely open, so it's not like the child's closed in at all. But there's three primary ways we use it. So the first is providing support and or partial weight bearing as needed for functional activities. So if you recall the picture on a previous slide of the child standing in the cage, he had a belt around his waist similar to this picture, and the bungee cords attached to each corner. But he was actually standing on the ground. Kids can also be in sitting position. They can be on hands and knees. Lots of different positions they can be in. But we can also work on their balance and strengthening as well. So we might have a child standing in the cage but doing squats or doing step-ups onto a platform. So there's lots of ways to utilize the cage that way. The next way is to isolate muscles for strengthening or stretching. So what we do is we bring a table into the cage and we use pulleys and weights to attach to their lower extremities. Often we use a knee immobilizer as well, and basically it just keeps their legs straight. So what we're trying to do is avoid certain movements because a lot of times the children have an abnormal signal from their brain to their muscles, and we may ask them to do a certain motion and they try very hard to do that, but unfortunately they're activating other muscles and we're not getting the movement that we're looking for. So to use the pulleys and weights and the knee immobilizer, we're actually isolating certain muscles, and a lot of times they're the hip muscles. And in order to improve their ambulation and other functional skills, those muscles are really important to strengthen. So the use of the cage in that way is very beneficial for lots of kids. The last way is the picture that you see. So this little guy is actually suspended in the cage. The bungee cords are elevated to the top of the cage, and he is hanging out. And so we do a lot of jumping and swinging, and the kids they love it. They're having a blast. We call it flying in the cage. We also use it as a reward, and a lot of times they don't even realize we're still getting work out of them. So it really takes a lot of core work to keep their bodies upright and their neck upright as well. So when the children start to get tired, their head might drop, and then we just say, oh, you got to get your head up if you want to keep flying. And so we're getting really good strengthening out of them, and they're having a blast while they do it. So it really is, I think, one of the best activities that we do in the clinic. Okay, next we have the therapy suit. When Euro-Peds first started doing suit therapy, we did use the original Russian Adeli suit. And after a couple of years, we always kept finding ourselves saying, I wish it had this, I wish it did that, I wish we could, do it this way. So the therapists here at Euro-Peds put their heads together, and we actually designed a suit that, of course, we think is new and improved. And so we added padding to the shoulders, and we have access between the legs just in case they need to use the bathroom in the middle of suit therapy or their diaper needs to be changed. So it really cut down on the amount of time to put the suit on and take it off. So it consists of soft cloth. It's worn over the clothing. You'll see there's a vest, there's shorts, there's knee pads, and then on the shoes there's attachments for the resistive bands, which are the bands you see that are yellow. There's also Velcro and straps that connect the pieces together. So you'll see the vest is connected to the shorts with those straps. And it's important that it's really snug fitting on their body so that the resistive bands are able to do what they need to do. The resistive bands align the body. So a lot of times there's certain patterns of posture that these children have because of weak musculature or maybe increased tone that we've talked about. So we can help align the body into a better posture. The bands also create compression throughout the joints, which it helps with learning, and it also helps to create more body awareness. When we talked about the kids with low tone in particular, they have a lack of body awareness. So to increase that compression through the body helps them realize where their arms and legs are in space. So the bands are put on specifically to mimic certain muscle groups, and they're applied, to each child differently depending on their condition and their posture. And we do have to adjust them frequently, especially day to day, because tone especially fluctuates depending on what's going on with the child. So if somebody comes in really tired, their tone might be increased that day, or maybe they're, catching a cold. So we will see a change, and then we'll have to adjust the resistance on the bands and maybe even the position of the bands to get, the proper posture and the amount of tension that we want for them. So the outcomes that suit therapy provides is increased motor learning through enhanced sensory input, also increasing strength and endurance, improving balance and coordination, improving their alignment, and increasing their motor control in general. There are a few reasons why the suit isn't a good option for some children, and the most common reason is hip subluxation. So basically what that means, it's very common, especially with the children that have increased tone. A lot of times they have increased tone in the inner thigh muscles, the adductors, and this basically puts a force on the bone that makes it want to come out of alignment. So if it's a minimal subluxation, meaning that hip is coming out of, kind of uncovered a little bit, then we can still use the suit. But if it's greater, then usually it's about 33%. If it's greater than 33%, we are concerned about the forces that the suit is putting on the body, and we wouldn't want to take that risk. It just wouldn't be a good option for that child. So we do take a look at hip x-rays to take a look at the structure of the hip and to see how much subluxation, if any, is present. Same thing with scoliosis. If it's a mild scoliosis or curvature of the spine, the suit could be beneficial if it's a functional, it's like kind of coming from the muscles instead of a bony alignment issue. But if the scoliosis is more severe, the suit is not going to be the best option for them because the forces that it puts on the body could actually be too much for them and could impact their organs. So we do take, assessing for suit very seriously and do, review radiology films if needed. And in general, just take a look at the whole child and what they have going on medically to make sure that it's a good option. A lot of times we make modifications. A lot of our kids have a baclofen pump or a G-tube or maybe have a shunt. And so we can add extra padding just to make sure that there's no irritation over the baclofen pump or the G-tube. So there's lots of modifications we can do as well. Okay, moving on to research. Hopefully I don't lose you guys in this section. Sometimes this gets a little boring for some people. So let's see if we can get through this. The first slide that you see is showing some data that was collected at Euro-Peds. And basically all of the children, there were 30 patients that we looked at. They received 4 hours of therapy 5 days a week for 2 weeks. So what happened is upon their evaluation, we took a look at what functional skills they were able to do. And we determined how much assistance they needed. So you'll see in the table there's unassisted, meaning they could do it by themselves, minimum assistance needing 25% or less, moderate 50% or less, maximum 75% or less, and then completely dependent meant they needed 76% or more assistance in order to complete that function. And we looked at multiple functions. So after the 2-week session, we looked at all of those things again and determined how much assistance they needed. So the first bar says 43% unassisted. And what that means is that 43% of our kiddos learned a functional skill over that 2-week period unassisted. They were able to leave here learning something that they could do by themselves. The next bar is 37%. And those were the kids that advanced 2 levels. So let's just say they needed 75% assistance to stand up from the floor. when they started. 2 weeks later, they needed less than 25% assistance in order to stand up from the floor. So a pretty significant improvement in 2 weeks' time. The last bar you see is 20% advancing 1 level. And then the other categories we had was slight increase and no improvement. And you can see none of the kiddos fell into that category. So we were really, really proud of these results because in a 2-week time period, for 43% of the kids to learn a skill unassisted, it's huge, and we're really proud of what they're able to accomplish. All right, there is some studies that have been done on intensive therapy. So the first that we'll talk about looked at therapy 4 times per week, 4 weeks on, 8 weeks off for a total of 6 months. And they did have statistically significant increases in their GMFM scores. And they also found that the participants maintained their improvements in motor function during the 2 8-week rest periods. There were also 3 successive studies done by Bauer and McClellan, and it was a randomized controlled trial of therapy 5 times a week, 6 months on and 6 months off. And their results showed a trend toward greater success with intensive therapy. We participated in a study with Oakland University, and they looked at 19 children with CP, divided them into a 5-week program of either conductive education, intensive PT, or a special education program. And they had blinded testers, which basically means therapists that didn't know which therapies these kids were receiving. And they performed 3 different tests, the PD, the GMFM, and the P-body, before and after the 5-week session. And the intensive therapy group was the only group with statistically significant changes in function before and after the 5-week session. Euro-Peds did a pilot study, and we also used the GMFM, which is a common test that therapists use to determine gains in function. So it was used before and after the 2-week program that was combined with suit therapy. There were 9 children. They did 2 weeks of therapy, 5 days a week, 4 hours a day, and they were in the suit for approximately 1 to 2 hours. So the conclusions of the pilot study was that the combination of intensive PT and suit therapy reduces functional limitations and provides for a lesser degree of dependence. I thought it was interesting, and I compared the 2 studies that two of the studies we just spoke about. When you look at the study by Trahan and Malloyne, they did therapy 4 days a week. It was 45 minutes of PT, 45 minutes of OT. So it was 30 treatments over 6 months, which equates to 45 hours of therapy. And their increase in their GMFM scores, it was a mean of 9.2%. And then when you take a look at the Euro-Peds pilot study, it was 4 hours of PT a day, which is 10 sessions over 2 weeks. Which equates to 40 hours in a 2-week period. And the mean GMFM scores was an increase of 7.3%. So it just makes you stop and think that 10 sessions over 2 weeks of Euro-Peds intense therapy may be close to as effective as 30 sessions over 6 months of a less intense therapy program. And again, this other program was intensive itself. So it makes you wonder if you were to compare, and that's what we need to do, more research, compare intensive therapy to some of the traditional therapies to see what the gains are. But it really just shows us that more research needs to be done, and we really need to be taking a look at the duration of therapy and how often these breaks need to happen to really maximize the gains. So I'm sure a lot of you are questioning whether or not the results are maintainable, because obviously it's great that they make these gains in 2 weeks, but if they don't maintain them, then it's really not worth it. But the good news is research is finding that it is maintainable, and some of the studies we just talked about, they had mentioned that. So I just pulled some statements from the Trahan and Malloyne study. Then they stated that sequences of short intensive therapy periods alternating with longer rest periods seem to optimize the effects of motor training. The performance of the children did not deteriorate during the rest periods, And again, it highlights the need to reconsider the way PT rehabilitation programs are organized. We also work a lot with, before we move on to home exercise program, work a lot with referrals to other specialists. So, you know, our focus here is physical therapy, but we know full well that there's so many other aspects of these children's lives that they may need assistance with. So quite often we have orthotists that come to the clinic and they may do casting for different bracing. We refer out to OTs, to speech therapists, neurologists, orthopedics, PM&R, surgeons. We try to educate on different treatment options out there. There's dorsal rhizotomies and percutaneous tendon lengthenings, baclofen pump. Lots of families ask us about Botox. So we wouldn't necessarily be the ones to recommend a specific treatment option, but we can educate you on them and then refer you to a physician so that you can look into it more if you're interested. Also, lots of equipment recommendations. We have lots of different pieces of equipment here to try because every child does respond differently to you know, different types of assistance, especially when it comes to gait trainers. So we've got different kinds. We've got ones that you know, have arm troughs that really give them stability for their upper extremities. We have others that are more hands-free, and some kids do much better with those. So we do, you know, want to make sure that we're confident in what we're recommending, since insurance is only covering, you know, a certain piece of equipment every several years. So it is nice to be able to try different things out. So the next is a home exercise program. It's one of the things that I think is really important, part of an intensive program. We try to get to know our kiddos and, of course, the families and understand what kind of support they have at home. And then customize it for their situation. So for a family that's very, very busy, has other children, and is always on the go, the home exercise program is probably going to be more focused on a couple of activities. We have some families that have you know, grandparents that live next door, older siblings that are really interested in physical therapy, maybe students that come into the home a couple times a week. And if that's the case, then we might give a more elaborate home exercise program because the families have the support to carry it out. But basically, we're going to maintain the newly learned skills and then allow them to continue to progress to the next step. We do photo home exercise programs where we actually take digital pictures of the child doing the activities that we're recommending, and then we have written instruction as well. So just to point out alignment or how many reps of a certain activity you should do. We also do video home exercise programs where we videotape the activities, and the therapist will talk through them to explain what it is you need to be looking at. So the alignment of the body. Should the toes be pointed up or should they be pointed out to the side? It's those kind of things that I think quite often when families get home, they can't remember, oh my gosh, I can't remember exactly how she looked when we were doing this. So I think the photo and video HEPs really help to make sure that we're all focused on the right things with these kids. It also helps when it's shared with caregivers, and even school PTs quite often say, hey, can we get a copy of that, because we can implement it into what we're working on as well. So it's very customized and very detailed. A lot of these kids have certain alignment issues, or maybe their hips are subluxed and we need to avoid certain positions, and so we're able to really make sure that it's the best program for each kid. So this is a intensive physical therapy checklist, just some things to think about. Are they individualized sessions? There's some programs that, if you spend an hour in the cage, an hour in the suit, you really just want to make sure that it's individualized since the kids are all so different. I think it's important to ask if the PTs and the PTAs are licensed. In the state of Michigan, it's required, and I think in most states it's required. Adequate training period for the therapist and ongoing training. This is a specialized type of therapy, so you just want to make sure that people are trained appropriately, that they're experienced in treating gross motor delays, and in working with children or young adults. I do think that there's something to be said about the professionals that work exclusively with children or young adults. Just the creativity and the ability to work with them, I think, excuse me, is important. Also, the home exercise programs, making sure there is one and that they are detailed. If you have medical insurance, I think that's a great question to ask, whether or not the clinic accepts insurance. Financial assistance, if you know, maybe there's a large deductible or co-insurance, or maybe insurance isn't covering the therapy, is there any financial assistance to help with out-of-pocket costs? Asking whether or not they're involved in research studies. I think that's interesting to know. Whether or not there's a suit assessment. So we touched on just a few of the reasons why the suit might not be a good option for everybody. So that's something that I would want everybody to consider. And then emergency medical services nearby. A lot of the kids that we work with, you know, have seizure activity, or you know, may have a feeding tube, and if that comes out, then you know, you need quick medical assistance to get that put back in. So just some things to think about. You know, Euro-Peds opened back in 1999, and probably, I would say within about 5 years, some other centers started opening up, and everybody's kind of doing their own kind of programming. But I think those questions will, you know, help you to find the right program for you. For those of you who might be interested in Euro-Peds therapy, the first step is to fill out a patient application, and it is found on our website. There's an online version that you can submit electronically, or you can download the PDF and fill it out and either fax it in, mail it in, or scan it and email it in to us. I review each application, and I do ask about medical history. So if there's any concerns at all, I just pick up the phone and give you a call, and you know, just get clarification. So probably the most common, a couple common reasons I would call is if the seizure activity is pretty frequent, or they're more grand mal seizures. I may want more information just to understand how controlled those seizures are, and if fatigue increases them, that type of thing. There's also some patients that have cardiac concerns, and so I'll just want to learn a little bit more about that, and I may even want to reach out to the cardiologist just to make sure that, you know, they feel that an intensive program would be beneficial for the kiddo. After the determination is made, the front office staff contacts the family with the determination and discusses insurance coverage and if there's any out-of-pocket costs, and also the scheduling options that are available. We also have a foundation that we started just a couple of years ago, and the foundation provides treatment and travel grants for children to attend Euro-Peds. We accept most insurances, but in this day and age, there's high deductibles, co-insurance, co-pays. We do have families that travel from across the country, and at times their insurance may cover therapy within their own state, but not in the state of Michigan. So the Medicaid programs are usually that way. So if that's the case, there's going to be out-of-pocket costs, and we just want to help any family that we can to make it possible to get this, you know, specialized therapy. There's also travel costs associated for people that are coming from far away. So hotel costs can be covered by applying for a grant. So the Euro-Peds Foundation is a separate entity from the clinic. It has its own webpage, and so I've listed that there for you if you want more information, or if you'd like to download a grant application, you can do that. I think that is about all that I have to share with you today. I certainly appreciate you listening in, and I would love to answer any questions that you have. I think Dawn mentioned that you'll see that there is, you have the ability to type in any questions you have, and you know, we'd be happy to answer them.
Great. Thank you very much, Michelle. And if anybody has questions, if you want to go ahead and type those in the chat area, the question area, that would be great. And then while we're also doing that, we have a couple other poll questions and I'd like to just launch those quickly. The first one would be, this is maybe before you participated today, how familiar are you with intensive physical therapy? Okay. Good, good. It looks like we had kind of across the board, 36 extremely familiar, 43 somewhat familiar, and 21% not very familiar. So thank you for that. And then another question would be, just curious, have you ever visited Euro-Peds National Center before in Pontiac, Michigan? And for those of you who haven't visited, last year Euro-Peds was very fortunate to buy and move into a beautiful new one-story building. It's really convenient off the highway and I-75 right in the corner of Auburn Hills and Pontiac, and it's there's a virtual tour on the Euro-Peds website, so you can take a virtual tour, and then you can also contact the clinic or let us know, and we'd be happy to set up a tour for you. And that's really like one of the best ways to really see the center and interact with Michelle and the staff is to come out and take a visit if that's possible for you. So, but in the meantime, if you would like to take a tour online, there's through Google, we have a spin tour, which is an online tour where you can really just like going to view, homes online. You can kind of tour the whole center in a virtual tour. And the last question is just to kind of gauge after today's webinar, how interested are you in more information about Euro-Peds? Great. Thank you very much, everyone. Looks like we have a really interested group. So we hope to be able to follow up with you, and you're welcome to call the clinic, email Michelle, go online. I'm happy to answer questions from the parent's perspective, and we really look forward to helping you get the information that you need. Also, Euro-Peds is constantly recruiting talented physical therapists and PTAs, so if you are a medical professional and considering kind of a new career path or a different location, and you think Euro-Peds might be for you, then please reach out to Michelle as well. Okay, we do have a couple questions. Michelle, I'll just go through these, and if more come in, then I'll go there too. The first question would be, is Euro-Peds most helpful for children with mild or more severe motor challenges?
That's a good question. We work with all children of all abilities. So we've got some kids where we're focused really on core strengthening and head control and learning to roll over, or maybe even holding their head up in a seated position. And then we work all the way through the continuum of kids that maybe come in walking independently, but they have some balance and coordination concerns. So we're going to really work on their endurance, their balance and coordination to make them more safe of an ambulator. So I wouldn't say that this program is geared toward one or the other. It really, because it's so individualized, I think that it can benefit children of all abilities. And just to touch on that, sometimes I get a question about cognitive impairments. We are to work with children, again, of all abilities. So even if a child is nonverbal and can't communicate, we're obviously trained to work with children and, pick up on body language, or may even turn to the parents to help us learn, what facial expressions and grimaces they make, when they're upset or in pain, so that way we can know, the treatment that we're providing, making sure that it's comfortable for them and beneficial. So I would say that it's open to anyone with any kind of motor delay.
Okay, great. And I see another question here that says, how do you know if a child can tolerate the amount of time needed to participate in intensive physical therapy?
Yeah, that's a really good question as well. From experience, we just celebrated our 17th anniversary. So we've seen obviously lots of kids, over 1,500 children, and so we've learned that there's certain diagnoses that the kids might have less tolerance. There's also the component of age. Usually under the age of 2, and again, I'm saying usually because we actually had a 9-month-old that did a long, like a 3 to 4 hour treatment session, and even I was shocked by that. But typically under the age of 2, we're going to recommend 2 hours a day. Once they're past the age of 2, they tend to be able to tolerate a 4-hour session. But it really does depend on their diagnosis as well. If they have tight musculature, there's treatment techniques that we're going to do that's going to allow them to be treated for a longer period of time. If it's a child with low tone and maybe those techniques aren't needed, we might not need to treat them, 4 hours a day. We might be able to get done what we need to get done in 2 to 3 hours. So when I get that application and I look through the whole medical history, and if I have any concerns, I call the parents and talk to them about it and find out how much therapy have they done before. So it really is, it's a judgment call on the diagnosis, the age of the child, and what they have tolerated before. And of course the parent's opinion, if they say, man, my child gets tuckered out after an hour of speech therapy, then we're probably going to start off the first session at a lower duration and intensity and see how they do. And then once we've treated a child, the therapist communicates with the family. It's like, oh, they did really good with the 2-hour program. I think you could repeat that again, or I really think they could benefit from the 4-hour program. So there is a lot of discussion that's had. And we're going to be open and honest with you and let the families know what we think. Usually the first time a child comes, we do recommend a 2-week program, just so that you guys know the child can adapt to what we're asking for. We get to know the child. You guys get a sense of what this is all about, and again, the therapist can make recommendations for a future visit.
Great. Okay, I've got another question about gains. The question is, how do families help their child maintain the gains, and how often do kids need to come back?
Yeah, so maintaining the gains, our goal is to make sure that the gains are in a functional form. So, for a child who came in using a walker and we taught them how to use crutches, and so we are going to ask to incorporate that into their daily routine. So, using that example, they might not be 100% confident using those crutches when they leave here. And so maybe it's not appropriate to do it at school to begin with, but the goal would be to use their crutches at school. So then we would say, okay, so you don't have to use them while you're at school, but if you go to the grocery store, we want you to use them. Or if we, walking around the house, we want you to use them. So we try to incorporate it into daily life, because then that whole definition of motor learning, and it becomes automatic. And that's really what we want. Like, who cares if they can do 20 push-ups? Like, we really just want to make sure they're more functional throughout the day. So we try to incorporate it into their daily lives, and that's where the home exercise program comes in as well. As far as how often to return, it really, really depends on so many factors. The child, of course, and then also the family dynamics. We know it's not easy to move to Michigan for 2 or 3 weeks at a time. So it really, it's a combination. We're going to make recommendations, but we've got some kids that come once a year, we've got some that come twice a year, and then we've got some that come more and some that come less. And I also want to mention, we're talking a lot about the 4-hour a day or 2-hour a day program every day for 2 or 3 weeks. We do also have, for the families that live locally, we have programs that are 1.5 or 2 hours a day, 2 to 3 days a week, and they go on for several months at a time. So there is some other programs that we offer. And again, if you live far away, that's probably not feasible. But for the kids that live locally, sometimes they'll do an intensive 2-week session every day, and then they'll take a break, and then they'll come back and do, twice a week at 2 hours a session, for a couple of months. So there is a whole lot of variety, and it really just depends on the child's tolerance, what other therapies they're involved in, and then what the family has available.
Okay, great. And I can tell you from experience, I think Darren has done every single combination of those therapies, and every time he's had, increased gains, and it's been great. Okay, our next question is about the Euro-Peds Foundation. Who should apply, and does a grant cover the entire treatment?
Okay, that's a good question. If you go to the website, you will see the criteria to apply. I would say almost everybody should apply, especially if you need financial assistance. So there is no financial income criteria. We do ask for that information, but then we ask for what your family situation is. So we know some people might make a good amount of money, but they've got a huge deductible, and they have to pay out of pocket for their braces, and they have to pay out of pocket for this and that, and then they have 3 other children, 2 of which are in college, right? So there's always unique situations that every family's in. So I would say anybody can apply, and just share as much information about your situation that you can. Right now, the foundation is offering grants, treatment grants up to $1,500 and travel grants up to $800. So for some people, that's all of their out-of-pocket. But for some people who have to pay completely out of pocket, those grants won't cover the entire session. It's my goal to grow the foundation and raise enough funds that we will be able to cover entire sessions for those that need it. So that's what we're working toward, but of course we've got a lot of work to do in order to raise more money to make that possible. But I would encourage anybody that really could use help to go ahead and apply.
Okay, and just a quick question I was thinking about to maybe go along with that would be, maybe we should talk a little bit about our Adopt a Euro-Kid program. That's an extension of fundraising that some patients and parents do to help raise additional funds to cover treatment and travel.
Yeah, that's a really good point, Dawn. Yeah, so some families, so let's just say, to give an example, a family from out of state has a Medicaid program, but they're coming here for their therapy, so the Medicaid won't cover services in Michigan. So we have families that they can still apply for a grant, a treatment and travel grant, but then, through their application, we determine, they have a greater need than what we can provide through grants. We have the program that's called Adopt a Euro-Kid, and basically we set up a fundraising platform online, and, we get you the password, and you can or we can help you set it up. Upload pictures of your child and just a little bit of information, and then you share that link out with all of your family and friends. Social media is a great thing when it comes to this, because it really can help you spread the word. It's also on our Euro-Peds Foundation website, and people can donate to your specific child's treatment session. And there's some criteria. The money has to be used within a certain time frame, and any money that's raised in excess of the cost will just help another child. But it's a great way. We've had a couple kids do it, and they've been able to raise the money they needed to cover the whole thing. So we want to support families as much as we can. Fundraisers are happening. We're happy to try and spread the word to create more awareness and maybe even get a news story covered. So the Adopt a Euro-Kid program is a good option for some families.
Great. Okay, that is all. Those are all the questions that I see at this point, and I know we're at the end of our session for today. So thank you very much, Michelle, and for your information and for sharing more about the Euro-Peds program and about Euro-Peds Foundation. And thank you to all of the attendees that are with us today. We really appreciate that you took time out of your day to learn more about intensive physical therapy. We will follow up with some email links to the websites and also the recorded link in case you would like to share this with friends and family. I think for me that's been helpful through the years to share more information with grandparents and aunts and uncles so that they better understand kind of what's happening in your family and the treatment and work that you go through to really help your child. So if that's, I think that's all the questions. I'd just like to again thank everybody for joining us today, and we look forward to putting on more specific webinars about specific treatment programs and equipment in the future. So thank you very much, everyone.
Thanks, everybody. Appreciate your time.